Okay, so we're going to move back to a surgical session, and Dr. Scudamore couldn't make it as originally shown on the program, so we're going to hear entirely from Dr. Liu, who is a surgical oncologist from Vanderbilt University in Nashville, Tennessee, and he's going to give us two back-to-back presentations. One will be on mesenteric resections, and the other is going to be on surgery versus imaging.
Thank you so much. Now, I'm like Dr. Oderosio. I'm just a simple country surgeon from Tennessee, so please be good to me, be kind to me. And since I am a surgeon, I like lots of colorful pictures and cartoons and very few numbers. So if you're looking for numbers, I can't really help you. But I can show you a bunch of pictures. Actually, because of the short time, I'm just going to talk very shortly about mesenteric resection. There isn't much. That's more of a technical thing, something that we have to worry about that you don't have to worry about so much. But we'll talk a little bit about the importance of it. But really what I want to talk about and stress is the fact that technology has advanced so much, and that because we keep talking about multidisciplinary, this is where a lot of it comes together. This is where the technology comes together with the good old-fashioned surgical technique. And I'd like to show you how we can use it, how it's really advanced our ability to not only diagnose, but preoperatively diagnose, but also improve our ability to do surgery. And that's Vanderbilt. So we have a few good old-fashioned surgical detection devices. We still use our hands, sometimes in various positions, depending on what the situation is. We have our eyes, and sometimes we have to enhance those. And for, rectal carcinoids, we have our nose. That's what gets us through it. But let's not forget, these are the God-given surgical detection devices that have been used for 1,000 years. And they still work very, very well, as you saw in Dr. Palmier's lecture yesterday. But there have been advances in imaging. You can see that was the first X-ray ever taken on the left. We have chest X-rays and abdominal X-rays. And it's really helped us better visualize, better understand the disease, better diagnose. We talk about technology and how it's allowed us to improve our ability to make diagnoses. This is what we've been striving for hundreds of years. And even with the X-ray, we were able to improve our ability to decide whether to operate, decide not to operate, where to operate, when, what part of the body. Because when someone walks in the door, it can be a little confusing, It can be a little confusing. So what standard imaging techniques do we have now? And I'm sure most people in this room have had one of these tests. Certainly there's the good old-fashioned CT scan, which does a lot for us. It's an X-ray that can be, nowadays is incredibly fast, incredibly high resolution. This is a patient who I operated on a couple of weeks ago. He has, you can see on the left side of the screen, a transaxial image, and then a reconstruction and a coronal view. And you can see he has a little tumor right here, or maybe not so little, depending on how you look at it. But he had a pancreatic neuroendocrine tumor, and how was it diagnosed? He had a kidney stone. Had another CT scan that passed, and they said, "Oh, by the way, you got this thing on your pancreas. You should probably get that taken care of." Well, it turned out to be a Ki-67 of 5. Turned out to be a relatively well differentiated neuroendocrine tumor, and we took it out, and I hope he'll be okay. But you see, this is a very powerful technique, and it's very useful and helps guide us in our operation. In fact, I did his operation laparoscopically, so we removed his distal pancreas laparoscopically. Sometimes it helps us to decide when you don't operate, and you can see here a few images of of various patients with very, very diffuse liver disease. And it helps you decide maybe the person isn't a good candidate because their livers are so poor, there may be some issues going on there. Or sometimes the patient will have distant lung mets, and you have to decide too. So all this information going together helps us decide when to do surgery, decide how to do surgery, and decide who's going to be best suited for surgery. Now the MRI has been a very powerful technique, and you can see here's a rolling movie of a patient. You can see it's a very high resolution picture of your innards. And what I use it for is actually to take very fine pictures of the liver, because the CT scan is great, but the MRI gives you a lot of information and is able to kind of acts as a troubleshooter, because sometimes you can't figure out if a liver lesion is maybe a benign. Tell me if this is familiar. Oh, it's a hemangioma. Oh, it's just an adenoma. Oh, actually, it's a metastatic tumor. So the MRI is actually very powerful there too, because it helps me decide, what to cut, because you certainly don't want to cut into a bag full of blood vessels. That would be very dangerous. Endoscopy, of course, has become just absolutely routine, and it's an incredibly powerful technique, especially for gastroenteric tumors. And you can see just on the left side, that's just the classic polyp that you would see in a normal colonoscopy. But you can see that you can visualize the lesion, you can localize the lesion, you can put a tag into it, so when you go do surgery, you can go after it. Sometimes you have a lesion in the small bowel, and you have to resort to either double balloon endoscopy, or of course the pill endoscopy is very powerful. And so all these techniques have really advanced our ability to do surgery precisely, and to improve the diagnostics for the patient. Yeah, I particularly like ultrasound because I think, one, I can control it, and two, it gives you a ton of information. I'm sure a fair amount of people here in this room have had endoscopic ultrasounds before, and FNA, if that sounds familiar. Before we have to operate on you, get a small piece of tissue in order to just to make a diagnosis. Well, nowadays, in the patient I operated on before, in fact, he had an EUS, an endoscopic ultrasound from above. He had a fine needle aspiration, tolerated very well, went home that day, and by the end of the next day, we had a diagnosis of neuroendocrine tumor. And that's a big deal because, if you do general surgical oncology, like a lot of us do, you'll see it's sometimes difficult to discern, well, what if the patient's asymptomatic? Maybe he has pancreatic cancer, right? And that's a very different diagnosis and kind of a very different way of approaching it. So the endoscopic ultrasound gives us a lot of information. And of course, even in the operating room, it's very important to do ultrasound because it essentially makes the liver transparent, and it's being able to see through the liver. And as Dr. Pommier said, sometimes you have to go in there and cut through the liver and dig out your tumor. The ultrasound is a very, very powerful tool that we can use in the operating room to see that. So those are wonderful imaging techniques for improving our ability to do surgery. But when it comes to imaging, I think there's been a real revolution in the past 5 or 10 years, and I think that it's, for people who have had FDG PETs, that's just the very tip of the iceberg of the technology. I kind of think of the CT as a black and white TV, and the PET scan as a color, and hopefully someday we'll have HD at some point. But for those of you who aren't so familiar with the nuclear imaging techniques, we heard a little bit yesterday. We heard that PET scans, the typical FDG PET scans, are good for poorly differentiated disease. And I'll show you a couple of pictures later about how it's actually can fail you. But the imaging technology we have now has improved immensely over the past 5 or 10 years. And since a lot of the scientists in this room have started working on this problem 15 years ago, when I was still in high school, you can see very clearly the improved, I'm sorry, I'm talking about that guy right there mostly. You can see how the technology has improved and how it's made a big difference in our ability to make diagnoses. And right now we're relying on really 3 fundamental technologies. One is a gamma camera, which you take a radioisotope that emits photons. We can improve upon that by combining that actually with a single photon emission with a CAT scan, so you can actually get the anatomical view with a little bit of color. And finally, the PET-CT, which I think is going to be more broadly available, and it will be a much more powerful technique that we're actually starting to work with at Vanderbilt and actually at Iowa too, with a new technology to North America, let's put it that way. So everyone knows about the octreotide scan. Octrea scan is the brand name. It's an Indian-based assay. It's been a real reliable workhorse for us. And but it's got its problems. It's a photon-based, so it's a gamma camera and spec-based technology. It takes 2 days to do the test. It's relatively sensitive, depending on the situation, let's put it that way, depending on your study you read. But it's not perfect. It's not so good for bone mets, and it has relatively low resolution, which is a problem for me. So here's that same patient who had that tumor in his pancreas, and you can see it's actually not bad. If you look in the tail of the pancreas, so if you look on the third image from the left, you can see there's that black spot right next to the spleen. Thank you very much. That, in fact, is his tumor, and it localized very, very well. The problem is, this is what I'm looking at, okay? And it's a little fuzzy, I think we would all agree with that. And if you got that from your cable system, I think you would probably want your money back, right? Oh, good. Thanks so much. So this is how my nuclear friends describe it. It's like looking at the sun through clouds. You know, it's a beautiful picture, and it works very well, but sometimes you can't get enough information out of it. And so that's where we are. But PET imaging, which is slightly different, that's based on positron emission, is actually gives you finer resolution, gives you probably higher sensitivity as well, and it just gives you much prettier pictures. And the pretty picture it's not just decorative; it actually means something. And there are basically I'm just going to talk about really four types of radio tracers for now. The classic FDG, which everyone can get, especially if you have advanced cancer. Some more selective ones, fluorinated DOPA, carbon-11 5-HTP. These are metabolically based molecules, but very difficult scans to get in the world. And finally, 68 gallium octreotide, which I think is important. So here's a patient of mine who was an unfortunate case. She had a large liver tumor and underwent a massive liver resection at a very prestigious university. They chose not to biopsy it beforehand, so they just assumed it was hepatic carcinoma. It turned out to be a poorly differentiated neuroendocrine tumor, and they didn't know that till afterwards. She had a lot of complications. And then she finally came to me. I said, well, you need a PET scan. Her surgeon refused to get her a PET scan, so we got a PET scan. And that's what we found. She has another lesion right here next to her duodenum. So, if she had that resected at the time of operation, maybe it would have saved her second operation. Now here I am scratching my head talking to this woman, well, you might need another operation, and she's not excited by that. So there you go. But it shows you very nicely how a poorly differentiated lesion can light up on FDG PET. But now with more specialized scans for people who have better differentiated disease, you can see there's a big difference between the octreotide scan and the PET scan. You can see, and this is a study that came out in 2008, and you can see here in slide B, this is your octreotide scan, which is actually not bad. You can see the lesion there. But if you look at the F18 scan DOPA, look at the resolution and the sensitivity of more lesions here. If I didn't know that, you may not operate all the way up there, and you may not be able to get into these lesions. And here is an HTP scan. And you can see, again, the resolution is very, very good. This is actually for a metastatic carcinoid. So you can see how much more information you can get, and it's very common sense. It would affect the way that you treat the patient, and especially the way I would operate on the patient, and how to get those lesions out. Sorry. There we go. Again, you can see more pictures. This is actually with a metastatic insulinoma from the same study. You can see it here in the middle. But if you had just done a octreotide scan, you'd say, well, his chest is pretty clear. Even if you had done a F18 DOPA scan, you see, well, he has pretty clear stuff, maybe a little thing here. But then, look how beautiful the C11 5-HTP scan is. Now you can see there are many multiple lesions. You know exactly where they are, and you have a good idea of how big they are. The problem is it's very difficult to get these. These are definitely ivory tower type scans. If you wanted an HTP scan, you'd have to go to Sweden, you'd have to go to Germany, you'd have to go to Rotterdam has maybe. And you could go to Memorial actually here in the United States, or Cornell in the United States, but they only do it once a month, and you're lucky if it actually gets done. So it's not so simple, but you can see the power of the information that comes from it. And here's a study just looking at 5-HTP, and you can see the data. The PET scans were able to pick up 95% of the lesions. The octreotide scan, 84%, and CT, only 79%. And if you got a PET scan, you can see, 50%, over 50% of the patients had more lesions, and only 30% had the same number of lesions. So there's definitely going to be more information that you can obtain from the PET scan. And you can see this is a CT scan, and I got this from the Swedish group. You can see you can overlay the anatomy of the CT scan, and you can pick up odd things. This is a breast metastasis from a carcinoid, and then here is a duodenal lesion, which was undetected on octreotide scan and was undetected. So this is how using this technology can actually help you find the primary before you go to the operating room. Now, one of the technologies that I think is extremely powerful, and I kind of sell it as the next generation of octreotide scan, is the gallium-68 scan. Gallium-68 is a PET emitter, But it's not an ivory tower thing. You can actually buy a small generator, and any hospital can essentially do it. And what it does is, this is the studies from Germany, from Richard Baum, who's really been one of the pioneers in this field. And you can see the resolution in very odd places and how you can overlay the information from your PET scan with your CAT scan. And you can get better sensitivity and better resolution, as I said before. Here's a lymph node you can see from a patient, a lymph node up in his neck. Here's another lesion, primary lesion that was found in the chest. And you can see how well it's imaged here in the PET scan. And then here's another lesion here, a paraspinal lesion, another lymph node that lights up incredibly well. And so by knowing about that disease, you may not have thought that person had metastatic disease, but now you have the correct information. You can see that the disease is worse than it really is, and it affects your way you treat them. Here's another gallium-68 scan from that same paper, and you can see just the resolution and the pictures. You know, compare that to the octreotide scan, and you can see how much more sensitivity we have and what that means to us. Here you can see the lesions here in the liver.
What does it mean to the surgeon?
So what does it mean to the surgeon? Let's say you have, a lot of the time, the good thing is that sensitivity of your hands is extremely high. But what if a patient has diffuse lung disease? You know, then if the patient's asymptomatic, would you really want to go after surgery? What if the person has diffuse bony disease? You know, it's those types of things. I have a patient who has a carcinoid who has an ocular metastasis. You know, and so at least I know that when he can't close his eyes, there's a lesion inside there. Now, do I really want to operate on him? He's completely asymptomatic. He's on somatostatin, so I know at least he's being treated, but do I really want to go in there? You know, it makes you weigh those things. It's more information for you. So again, here's another study. Here's some more pictures from the German group, and you can see the lesions, how well they light up. In the bottom, you can see there's a lesion that we didn't even notice. It was actually in the tail of the pancreas. Here's another lesion in the rectum. There's a rectal carcinoid. Sure, you can see the primary there, but you can also see right next to it, just in a few cuts down, a lymph node. You know, if you were to have done this operation initially, you may not have gone that deep and that far down in order to get that lymph node. And so that's how it does change your decision making. And sometimes if you're not feeling all the way down there, you don't always get that information tactilely. Here's another scan on. So here's another scan. Here's another scan in the pancreas, and what you can see is there was a primary in the head of the pancreas, which we would have felt, but there was a sub-centimeter lesion in the tail of the pancreas, which can be very difficult to appreciate. And even when you're open, when you're palpating, there's fat inside there. It can be difficult to appreciate this. So now, knowing that there's another primary inside there, you can go after that as well. So you can see how it affects the way we operate.
So it gives you a roadmap?
It gives you a better roadmap, a much, much better roadmap. Another lesion here in the chest. And here's a very nice picture of a lesion in the terminal ileum. That we probably would have seen in surgery, but the fact that you know about it beforehand, you know, you always want to have more information before the operation than less information. And this is what it is. This is a gallium-68 generator. This one produces gallium, this one produces coffee. So make sure that you know which spout you're drawing out from. But this is all that's involved. Now, don't get me wrong. It certainly takes a very highly trained radiopharmacist to deliver it. It obviously takes a great nuclear medicine physician to administer and to read the scans. But the technology exists. It can sit on a desktop, and it may be a new targeted ability to scan that is available, that can be available around the country. Actually, in the United States, at least, I know that the University of Iowa and Vanderbilt are starting to bring that technology to the United States anyway, to North America. And we're several years behind Europe. So hopefully in the next couple of years we can start to catch up and work with their experience and bring that technology here. Because I know it's a long flight, and the exchange rate is very poor right now. It's getting better, that's right. But Dr. Maudlin put this together and really summarized it very beautifully, because you can see with your FDG scan, which is the only PET you can get now, look how poor the sensitivity is for picking up lesions. It gets a little more precise with MRI. CT, our real workhorse, is getting up there, but you're missing still 20% of the lesions. As you combine these technologies with octreotide scans, you can see you're getting better and better. But really, here's where the magic is. And it can be done with carbon-11, fluorine-18, gallium, and even copper. But really, why? So as we were asked, you asked the question, well, what does it make a difference? Well, it makes a difference because we want to get as much as we can, and this is a very well documented study, a very well referenced study from Per Hellman in Sweden. And in his review of their carcinoid patients, they found that if you could resect the primary, just as Dr. Palmier said yesterday, you can improve the person's quality of life and the quantity of life. If you can get out the lymph nodes, you increase the quantity of life. And if they don't have any liver mets, you can see you really significantly extend the amount of life they have. So, sure, if you don't get out all the tissue and you don't get all the tumor, that's not a loss. It's not a failure. But if you can get it, why not get it? And we're in there. Here you can see some of this data from his study, which is almost 10 years old. You can see if you can get the mesenteric lymph nodes out, your survival is better, and without any liver mets. And here you can see by getting out the the mesenteric lymph nodes, you improve their survival. So it is definitely a goal. It is definitely a goal for surgery. And here's the technique, the surgical technique that Dr. Ackerström from Sweden also described. Basically what we do is if you have you can imagine here, this is a mesenteric metastasis, that's a large lymph node that's kind of sitting on these vessels. If they tell you, in general, we would say if this was, say, a pancreatic cancer or a colon cancer that creeped up here, this may be very difficult to operate on because that person is actually, the survival is going to be pretty poor. But someone with a carcinoid, it's a very different type of biology, it's a very different type of disease, and so we can get inside here and actually carve this out. And what he had pioneered is actually being able to get on both sides of the tumor and being able to peel it off from there. And a lot of the neuroendocrine surgeons will tell you, unlike an adenocarcinoma, you can actually peel a lot of that stuff off. So one other technology which is actually not widely used is this radioguided surgery. We talked about radio imaging, but in the operating room we can also do this. I do it all the time for breasts, in order to do sentinel lymph nodes. Everyone's heard of that. Well, there's no reason why we can't actually employ that technology in the operating room for neuroendocrine disease. It's a little tedious, and what you do basically is you inject indium. And then it's just like an arteriotide scan, but you use this handheld wand, and you go and you look for a signal. And wherever you find signal, you can find small lesions. The truth of the matter is, if you're very experienced, probably like Dr. Palmier, you can get all those lesions by hand. But sometimes, if you're a little less experienced, like me, a little bit something like this would certainly be very helpful, and we can try that. It's not widely used because I think it's a tedious technology, and I'm not sure it's really worked out. But you can see a study from 1998, even with just palpation, you could get most of the lesions. With your arteriotide scan, you got a lot of lesions. But with the probe, you actually got 70 more lesions on average from their operation.
Lesions you're talking about?
Down to 3 to 4 millimeters. Yeah, 1 millimeter. Okay, it's even better. And this is one final slide. I want to talk to you about some more image-guided surgery in the operating room. Vanderbilt's working closely with a company called Pathfinder. And as we had mentioned yesterday, it's good to get all those lesions out of the liver. And if they sit on the surface of the liver, you can see them and just core them out. But take a look at this. We are now doing preoperative evaluation of the liver where we can actually take CT images, make them color, and then manipulate in 3 dimensions. What that does, it actually helps me decide what is the safest way to preserve as much liver as possible, but to get as much tumor out. And you can see here the large blood vessels feeding the liver. Here's a large tumor here. This is not a neuroendocrine, but you get the idea. And I can come around here and know exactly how to resect that without doing the classic anatomic resection and forcing you to lose actually 50% more liver than you really need. We're employing that in the operating room, and you can see we use the probe actually to help and a camera right here to establish the certain points of reference. And then what we do is we actually use it, reconstruct it, and I can actually preoperatively plan how I want to do the operation. The computer will calculate how much liver is lost, how much tissue there is, what your margins are. It's an extremely powerful technology that can be used in real time. And so we are investigating that use now. For very experienced liver surgeons, maybe they'll say, yeah, you don't really need this. But the truth of the matter is, every little bit helps. And you can see here, I can decide actually how much of a resection plane, where I'm going to go, what's it going to cut out. And you can see here with this 3D rendering, I can see what kind of margin I'm going to get. So if I can do it and if I can use it, I will. And so this is, I think, where some of the advances in technology, the advances of imaging meet surgery. And ultimately, it's for the benefit of people, in this room and people elsewhere, where we can improve their outcomes, improve the quality of their operation, and hopefully improve the amount of time they have to live with their families and their friends. So I thank you for your attention. I thank you for for getting up so early to hear this. And you can see here, for any of you who have been to Sweden, this is the garden in the botanical garden. My son running around it in Uppsala. And these are just a couple of pictures of what has happened in Nashville. So you can see it was this is water very good. This is water gone bad. So anyway, thanks for your attention. I can answer any questions.